So, a very good morning to one and all. I'm Dr. Raghulnadhan, Senior Resident, currently working in the Department of Ophthalmology at Sri Laxminarayana Institute of Medical Sciences, Kudapakam, Pondicherry. At the outset, I would like to thank my dear colleagues in the Department of Ophthalmology, as well as the staff members who are in the department, who have provided me such a wonderful opportunity to present my lecture in front of this huge and magnificent forum. So quickly move on to our topic. So the topic for today is macular hole. So I have divided my topic into the initial part, which includes epidemiology, classification of macular hole, how to go about classifying a macular hole, and how to but, and how to prognosticate such patients based on the classification. We'll quickly review the pathogenesis of each of the macular holes. We'll also discuss the signs and symptoms of the patients who are presenting to us with macular holes. In addition, or in the end of the day, we'll also discuss in brief what could be the complications that can occur in such patients and how to go about managing a patient with a macular hole. So quickly move on to the definition of macular holes. A macular hole is nothing but a full thickness defect in the level of the neurosensory retina in the foveal center. Open clear. So this macular hole was first described in the year 1863 by Nam, followed by Ogilvy, who coined the term hole in the macula, which he did in the 19th century. So what are the prevalences of a macular hole? So the Baltimore study, which took place in the year 1950, stated that the prevalence of macular hole was 3.3 per 1,000 population, while in various South Indian studies, it has been found that the incidence of macular hole is 1.7 per 1,000 population. So what are the risk factors that are present or that can cause a patient to develop macular holes? So female gender, and older individuals who are more than 65 years of age are more prone to develop a idiopathic macular hole. So what are the clinical features of patients who present with a macular hole? So these elderly patients who are literally more than 65 years of age, especially the female population, these patients complain typically of a distorted image. So viewing a distorted image, which is also called as metamorphopsia, is the most common sign or most common symptom that a patient with a macular hole present to you with. The other symptom includes a central scotomas, which is nothing but seeing some black or an absence of an image, particularly while viewing an object or an image. The patient will complain of a central defect. Patient will not able to see the image which is present at the center of the object or the viewing image. So these signs are to be precise, the symptoms of metamorphopsia or a central scotoma presence, or it can vary based on the size or location of the macular hole, or it can vary in the presence or even absence of a retinal detachment. So quickly moving on to the signs of macular hole, the investigation of choice that we do in all patients who have a suspected macular hole is viewing the fundus using a slit lamp biomicroscopy with a handheld plus 90 diopter lens or a 78 diopter lens. Depending upon the stage of the macular hole, the appearance of the macular hole that we view in the slit lamp biomicroscopy varies. So how do we see a macular hole in a 90-day examination? Usually, a macular hole has got sides as well as a base. So the base of the hole, along the base of the hole, we usually see a yellowish white deposit, which is nothing but lipofuscin laden macrophages or a proliferation of retinal pigment epithelium. So whereas in case of a traumatic macular hole, we just see that the edges of the macular hole are going to be irregular and there is going to be an absence of a posterior vitreous detachment. The sides or the edges of an idiopathic macular hole, in the other hand, is going to be a regular edge. Okay, it's going to be a regular, and in case of an idiopathic macular hole, usually this posterior vitreous detachment may or may not be present. So what are the two subjective tests that we can do in such patients with macular hole? Yes, we do have two tests. One is the Vatsky-Allen test, where we do aim a narrow slit beam from a slit lamp biomicroscopy and we focus it at the level of the macular hole and we ask the patient uh, whether you are perceiving any light or no. However, a normal patient usually will see a narrow slit beam, while a patient with the macular hole usually complain of a bent or a pitched light, a bent or a pitched light beam that he is seeing. Okay. So moving on to the second subjective test, which is the laser aiming beam test, which is nothing but a 50 micron laser beam, which is being focused at the level of macular hole, which is projected into the macular hole. A normal patient can perceive this light, while a patient with a macular hole cannot perceive the aiming beam because there is absence of neurosensory retina at the level of the macular hole. So what are the various pathogenesis that have been proposed, that have been, or the theories which have been proposed, uh, which leads to the development of a macular hole? Firstly, we have a vascular theory which was described by Coates and Quint in the year 1930, who suggested that any vascular insufficiency in the macular area due to occlusion of the choroidal vessels which are present behind the retina can lead to a degenerative process at the level of neurosensory retina, which in turn can manifest as a macular hole. There is one more theory called as a traumatic theory, which is nothing but any blunt trauma that has occurred to the eye can always create a mechanical waves or generate a mechanical wave in the level of vitreous, or it can cause a cystic degeneration of the vitreous, which in turn can lead to either a macular necrosis or coalescence of the cyst, which in turn can lead to a macular hole. What about the rest of the theories? Yes, we do have a theory called as vascular or a cystoid degeneration theory, which is nothing but any presence of any vascular occlusions in the form of CRBO or BRBO or any arterial occlusion or in the presence of a severe hypertensive occlusive crisis can lead to a cystoid degeneration at the level of a neurosensory retina, which in turn can lead to development of a macular hole. We do have a theory called as vitreous theory, which was given by Eberg and Lister, which states that anterior-posterior traction of the vitreous can lead to a tractional macular detachment, which in turn can lead to a macular hole. How there are other theories which have been recently proposed, which states that an interplay between the anteroposterior vitreous traction or even a tangential vitreoretinal traction or any evolutional changes in the retina as suggested by Kurtz and Quinn can in turn all the three pathomechanisms can indeed lead to development of a macular hole. So quickly moving on to what to define what is a traumatic macular hole. Traumatic macular hole usually occurs in patients who have suffered a severe blunt trauma to the ocular surface. So usually such type of macular hole can occur immediately after the injury. in most patients. So what is the mechanism, or what are the mechanisms? Yeah, the mechanisms are almost similar to those patients with an idiopathic macular hole. However, the extra mechanism that occurs in a patient with traumatic macular hole is nothing but presence of a retinal stretching from deformation of the eye or force of the impact on the posterior pole, which in turn can lead to a macular hole. Cystic degeneration and detachment of the posterior vitreous are similar mechanisms that we have already seen in those patients with an idiopathic macular hole. So 80% of the patient with traumatic macular hole can have a posterior vitreous detachment, and a 15% can have a partial adherence of the vitreous. And one more thing I want to emphasize in such cases, the most common gender to develop a traumatic macular hole is going to be a uh, male patients. Okay, it is just the opposite of what we saw in an idiopathic macular hole. So, how to differentiate between a traumatic macular hole or an idiopathic macular hole? Most likely, the traumatic macular holes which we come across are eccentric, or they are less circular than an idiopathic macular hole with an horizontal diameter longer than the vertical diameter. And in case of an idiopathic macular hole, we come across the macular holes usually have a large basal diameter and a basal area. The idiopathic macular hole patients will have a less retinal thickness at the edge of the macular hole. Okay. So moving on to the OCT classification of macular hole, we do have a classification that was given by Chang in the year 1913, which has got multiple stages starting from 0 to 4. So stage 0 include just a presence of a perifoveal detachment, as shown in this image. Presence of just a perifoveal detachment with a normal foveal contour. 1A includes presence of a perifoveal vascular detachment of the posterior hyaloid along with the foveal cyst, presence of a foveal cyst. Okay. While 1B, which is also called as an occult macular hole, has a perifoveal detachment in the outer along with the foveal cyst in the outer retina. In addition to it, such patients will have a break in the photoreceptor layer. Moving on to stage 2. Stage 2 patients will have all the similar findings which are present in stage 0 and stage 1. Along with it, patients will have a partial opening, okay, a cyst groove, a partial opening of the cystic groove. But however, this groove is still attached to the operculum. We can also see a partial detachment of the posterior hyaloid. However, this detachment is still attached to the operculum. Stage 3 will have all the similar findings that we saw in stage 1 and 2. In addition, in stage 3, we do have a posterior hyaloid detachment from the macula. Okay, presence of a posterior hyaloid detachment along with findings of stage 1A and stage 2 is considered as a stage 3 macular hole, while stage 4 macular hole is entirely different from the rest of the stage, as these macular holes can be of variable sizes. However, these patients will have a complete posterior vitreous detachment, which cannot be seen in the ocular coherence tomography. Moving on to the gas classification of macular hole, which was based on just a slit lamp biomicroscopy. Uh, so, in such classification was an age-old classification which was given by Gas in the year 1837. So, he classified macular holes into stage 1A, 1B, stage 2, stage 3, and stage 4 based on the clinical appearances in the fundus microscope. Okay, so what is stage 1? Stage 1 and stage 1A and stage 2, stage 1B were considered as an impending macular hole, wherein Gas found that presence of just a central retinal yellow spot in the absence of a vitreofoveolar separation He classified those macular holes as stage 1A, while in stage 1B, he noticed such patients had an yellow ring in the absence of a perifoveolar vitreous separation. Stage 2 macular hole, according to Gas, had an eccentric oval crescent tick or an horseshoe retinal defect inside the edge of the yellow ring, or a central round retinal defects which are less than 400 microns in the presence or an absence of a perifoveolar opacity. While stage 3 macular hole patients usually had a macular hole defect, a retinal defect of more than or equal to 400 microns in the absence of a waveling, in the absence of an elevated retinal detachment, in the presence or absence of a perifoveolar opacity. While the stage 4, which is the end stage of macular hole, Gas classified such patients as those who had a macular hole of more than or equal to 400 microns in the presence of a posterior vitreous detachment, which can present as a V-sling, in the presence of an elevated retinal rim, and in the presence of a perifoveolar opacity. So what are the axillary investigations that can be done or performed in a patient with a macular hole? We can do a gonioscopy in such patients to rule out an angle recession. Not in all patients, gonioscopy is necessary. Gonioscopy can be done in those patients who had an history of a blunt trauma, which in turn can lead to an angle recession. Yes, we do perform ocular coherence tomography in all those patients with a macular hole, be it an idiopathic hole or a traumatic macular hole, just to classify the macular hole based on the OCT appearances, as well as to follow up such patients post or pre-treatment. So yes, we do perform a fundus autofluorescence in all such patients, as doing a fundus autofluorescence can have a prognostic value. So a full thickness macular hole usually have an hyperfluorescent fovea because of absence of neurosensory retina, thereby giving a way to view the choroid which is present underlying this area. We can also see a surrounding subretinal hypofluorescence in the presence of a subretinal fluid. A healthy retinal pigment epithelium on FAF usually indicates a better anatomical outcome post-surgery. Yes, we do perform an fundus fluorescent angiography, also called as FFA, in such patients with macular hole, just to stage the macular holes in for prognosticating purposes. So in stage 1, we just do see a faint hyperfluorescence at the level of fovea due to absence of neurosensory retina at the level of fovea. Whereas in stage 2, we do see a round hypofluorescent defect, or also called as a window defect, which may or may not be seen. While in stage 3 and stage 4 macular holes, we see a window defect with early transmission of hyperfluorescence in phase with a choroidal film. So how do we prognosticate such macular holes? So macular holes can be prognosticated based on their visual acuity at which the patient presents with. It can also be prognosticated based on the size of the macular hole, based on the repeating surgeries that the patient have undergone. We can also classify macular holes based on the presence of a pale disc or not, as presence of a pale disc indirectly indicates that the patient's vision is going to be poor post-surgery. Presence or absence of a choroidal rupture, presence or absence of a retinal atrophy, or presence or absence of significant signs of a glaucomatous optic cupping, or based on the macular hole indices, we do prognosticate macular holes. So quickly moving on to what are the treatment strategies for a macular hole. So macular hole can be classified into a primary macular hole or a persistent or a recurrent macular hole, which means that in spite of patient undergoing surgery for a macular hole in the form of a pars plana vitrectomy with an ILM peeling, the macular hole is still persisting or the macular hole has recurred. Okay, so moving on to primary macular holes. Uh, Primary macular holes has already been classified based on the size as a small macular hole which are less than 250 microns, a medium-sized to large-sized macular holes which are 250 to 400 microns, or a large-sized macular holes which are more than 400 microns. So a small sized macular hole with a good visual acuity of 20 by 40, say 6 by 9 or better, can be observed for up to 1 to 3 months, as studies suggest that macular holes, or a small sized macular hole with a good visual acuity of 6 by 9 or 20 by 40, usually closes or spontaneously resolves in 60% of the cases, while the rest of the patients may or may not need surgery if they progress to either a macular hole stage 2 or stage 3 or stage 4. Okay. So yeah, we do consider doing a surgery in macular hole, a small sized macular hole, in case of if the patient is having a deterioration in the visual acuity, or if the patient is severely symptomatic, if the patient is if the patient is having more metamorphopsia, or if the patient is having more visual field scotomas. Patient with the visual acuity of worse of 6 by 12 or 6 by 18 or worse can very well undergo a pars plana vitrectomy with an ILM or an inner limiting membrane peeling with application of a short-acting gas tamponade in the level of vitreous. A moderate-sized or a medium-sized macular hole can very well be treated with an ILM peeling after doing a pars plana vitrectomy with a gas tamponade. A large-sized macular hole can be treated with a pars plana vitrectomy, but instead of doing just an ILM peeling, weak patients can undergo an inverted flap. Basically, after peeling the inner limiting membrane, we, we tuck in the inner limiting membrane into the fovea, which acts as a scaffold for the inner neurosensory retina to grow. We do apply gas tamponade in such patients in the form of C3F8 or SF6. How to treat? Okay, this is for primary macular hole. How to treat a patient with a recurrent macular hole? So, in the presence of an inadequate an epiretinal membrane or an inadequate inner limiting membrane removal, we do perform a repeat pars plana vitrectomy. We extend the inner limiting membrane, or we do an ILM free flap. After doing the free flap, we inject either C3F8 or an SF6 gas for a tamponade effect. While in the absence of any of these two, we can consider doing an implant scaffold for glial proliferation, which in the form of an inner limiting membrane translocation or an insertion or a free flap, or we instead can do harvest the lens capsule flap fragments from the similar patient, and we can apply over the macular hole. We can also do a relieving macular hole stiffness surgery in the form of a macular hole hydrodissection, or we can even do promote the adhesion of the macular hole by using autologous serum in the form of an autologous blood plug, or by using an autologous platelet extract. We can use a substance called as oquiplasmin, which is nothing but a coagulative substance which can be applied over the macular hole, which in turn acts like a glue and helps in closure of the macular hole. However, use of oculoplasmin in patients have a high chance of the patient developing zonular weakness. Thereby, patient can develop an iatrogenic subluxation or an iatrogenic dislocation. So, what are the basic steps in a macular hole surgery? After painting and draping the patient uh, uh, is made to lie down and asked to focus on the slit lamp, the microscopic light. We do insert 3 sclerotomy incision at 4 millimeter, 3 millimeter, and 3.5 millimeter posterior to the limbus, based on whether the patient is phakic, aphakic, or pseudophakic, respectively. We do insert an irrigating cannula infratemporally, okay, and an endo-illumination probe under cutter supranasally and supratemporally. We do perform a pars plana vitrectomy, the core vitrectomy, using a 25 gauge cutter. We do induce the posterior vitreous detachment induction, and we do remove the posterior hyaloid. After removing the posterior hyaloid, we do perform an epiretinal membrane peeling if it's present after or before staining the ILM with dyes. So what are the various dyes that can be used in ILM peeling surgeries? We do use brilliant blue green, which is used at a concentration of 0.025%. And we can also use Tryphon blue in the form of 0.15% concentration, as well as indocyanine green in the form of 0.025 to 0.5%. So what are the basic steps? Post-staining, we do peel the inner limiting membrane using a max grip forceps or an end grip forceps, or using a diamond duster scraper. So post peeling of the macula, either we can remove the macula, the inner limiting membrane as a whole, or we can do an inverted flap tip technique, which acts as a scaffold for the neurosensory retina to grow over. So post surgery, we can give a fluid air exchange, and followed by which we can inject a sulfur hexafluoride gas or a C3 effect gas for a tamponade effect. And post injection of the gas, we remove all the trocars and we do suture the side ports. So we give a supine position, or we can give a proper position for the patient post surgery for better tamponade effect of the gases over the macula. So this is the management of a idiopathic macular hole. So how do we go about managing a large macular hole? So an important factor influencing a post-op functional and anatomical results is the macular hole diameter. So macular hole with a diameter of 400 micron or greater has an unsatisfactory surgical outcome even with the ILM peeling. So that's it, guys. Thank you so much for listening. You have been a great audience. Thank you so much. We'll call it a day. Goodbye.